Morning, everyone. To those who are just admitted from the waiting room, hi, thank you so much for coming. This is our first webinar with Dr. Marshall. She so graciously agreed to do this with us, so we thank her for being here. She has a strong interest in helping IMGs be successful throughout their medical school journey and beyond. And as you can see, she's an associate professor of medicine in the Division of Hematology at the Mayo Clinic, as well as an associate program director. So we are so thankful for her for being here, and we hope to see you guys at our next webinar. But if you submitted questions on the Google form, she will answer those after she goes through her very short presentation. And if not, we can take questions live right now after she goes through the presentation. And yeah, that's how we'll do it.
Great. Well, thank you so much. I'm really excited to have the opportunity to talk with you guys. I'm really passionate about medical education and passionate about diversity and inclusion. And I think there's just a lot of challenges that people face as international graduates when trying to match into the US. And there's a lot of, I'll be honest, there's a lot of stigma around IMGs. And as program directors, I think it's so important that we look at people's individual strengths and not just kind of the name that's on a transcript of a school or, you know, a location. I think we need to take into account people's individual strengths and what they've done, you know, with the opportunities available to them. So I'm very passionate, and a lot of this comes from my own experience as program leadership for our HEMONC fellowship, and seeing that some of our best fellows, smartest, most productive, most successful fellows are IMGs, and hearing kind of their stories about the challenges that they've faced. So I really have just a very few slides just as kind of a way to get the conversation going. And then I want to address your guys' questions individually. So I'll go through the slides. I'll probably take only 5-10 minutes. And then I got some of the questions ahead of time that I can definitely address, and then we'll open it up for everybody. So hopefully you guys can see as I advance the slides there. But just by way of background, so international graduates make up about 25% of our workforce as physicians. And the kind of baseline thing that needs to be done is to be certified by ECFMG, so the Educational Commission for Foreign Medical Graduates. And this needs to be done kind of at the end of medical school before starting a residency. So you need to do it before you take step 3 and before you start a training program in the US. And also you can't obtain an unrestricted license to practice in the US without this certification. So in terms of applying to residency itself, you know, assuming that you're ECFMG certified, you know, certainly USMLE scores are something that we take into account, although we'll talk a bit later about some changes in the scoring system. Letters of recommendation and the MSPE, the Medical Student Performance Evaluation, I have to say are probably the two most important things that people would take into account. The MSPE is essentially a dean's letter. So if you were to graduate from college, you would get a dean's letter. Graduating from medical school, you get this MSPE, which is essentially summarizing kind of your performance over the 4 years. And then you have your personal statement, any research that you've done, and any other pursuits. And this can be things like volunteer work, for example, or committees that you've been on. There are some changes coming up in the USMLE scores. So step 1, which traditionally has caused a lot of stress. You know, people spend a lot of time studying for this, and you know, there's some specialties where the score is very important. This is going to be only pass-fail as of 2022. So there are both pros and cons here. So the pros, it's going to be a lot less stressful to study for this, knowing that you simply have to pass the exam, rather than not only do you have to pass it, but you have to get a really high score on it, you know, especially if you want to go into a specialty, for example, like neurosurgery or dermatology, that's super competitive. We also know that scores on standardized testing don't predict how you do as a doctor whatsoever. So yes, scores on standardized testing match with one another. So if you do really well on step 1, you're probably going to do really well on step 2, and you're probably going to do good on your boards as well. But that doesn't really have any correlation with your clinical performance as a doctor. And hopefully, the lessened focus on kind of a number for your score will give you more time to do other things that are important for well-being and for becoming a good doctor, such as volunteer work, such as research. I think it is a little bit tricky though, because specifically for international graduates, where there's already kind of some level of stigma, the score used to be something that could actually set people apart. So for example, you're competing against a bunch of US graduates who kind of have that leg up on you, but if you got a really high score on step 1, perhaps that would give you an edge. And now if everybody gets a pass, you kind of don't get that extra edge anymore. So again, both pros and cons, but hopefully, overall it will lead to increased well-being, increased time, and other pursuits that you guys can take on. And then the CS exam for step 2 has been discontinued. At first it was temporary, and now that's probably a permanent discontinuation. Letters of recommendation are very important. I would say this and that performance evaluation are probably the 2 most important things. So really you need to distinguish yourself here, and you want it to be as specific as possible. So anybody can write a letter that says, I worked with person X and they were really great, and I suggest that you take them on to your residency. But that's not specific at all. That doesn't say anything about you, about what your personal strengths are. And even if they use words that sound really good, like superior, excellent, candidate, we need it to be specific. So a couple of buzzwords that you can pass on to letter writers are, hey, I was just wondering, could you quantify kind of where I stand in relation to other trainees that you supervise? We love seeing letters that say, this person is in the top 5% of all the medical students I've worked with, or this is one of the top 3 medical students I've ever worked with. Now, again, it becomes a little tricky because you do want to ask your letter writer, how strong of a letter can you write for me? And if they, for example, are going to say this person was in, the top 50% of all the medical students I've worked with, that's not going to be helpful to you at all. In fact, it might be harmful because you're really saying, they're kind of in the middle of the pack. So you want to be very specific when asking letter writers, hey, can you write me a very strong letter? Do you feel like I'm one of the top trainees that you've worked with? And if so, can you write me a strong letter and indicate that? We also know that there's a lot of kind of implicit bias that comes into letter writing, especially I have to say for women. One of my other big passions is gender equity for women in medicine, and a lot of people do this without even thinking about it. I'm guilty of it. Lots of other people are guilty of it. What's the first word that comes to mind? You're writing a letter of recommendation for a female trainee and you say things like compassionate and kind, and those are good things, but they also reinforce gender stereotypes. Whereas, a man may get terms such as accomplished and driven, and these are things that typically, in society we think of as good for men, but a woman, can't be too driven or it becomes aggressive, right? So really, asking the letter writers to stay away from these kind of divisive statements. So you want to emphasize, you want to ask them to emphasize accomplishments. So, I worked with this trainee and they were able to publish a paper within the course of a year, which is extraordinary. Or this trainee had the best score on our in-service exam of any of our trainees. But you don't want them to say things like compassionate or hardworking. I mean, those are okay if they're in addition to emphasizing your accomplishments, but you don't want the whole letter to be entirely, this is a really kind person that I really like, and therefore you should admit them to your residency program. And also things that may sound good at first, like, oh, they showed a lot of improvement over time. That causes a little bit of hesitation to us reading the letters because we think, oh, if they improved over time, was there a problem to start out with? So you really want the letter to be kind of strong across the board. And there are kind of tip sheets for letter writers that you might actually want to attach when you send them a request for a letter that draw their attention to things like the terminology and gender bias. Your personal statement is actually not as important as you might think. I talk to a lot of people that spend hours agonizing over their personal statement. And honestly, we really just give it a quick glance and are like, oh, that was a nice story. You know, that sounds good. But all that we really are making sure is, number one, you can write reasonably well. And number two, there's nothing odd that stands out about it. So the letter is one area where you don't want to stand out. You don't want to be known for, oh, that was the person who had the really weird story in their personal statement, or the person who came across as really arrogant. You want it to honestly be kind of bland. What it should basically cover is why you're interested in the specialty, how that ties into your overall story, and potentially a patient story. Those are always things that we like to see. So for example, say you're going into geriatrics, right? You could say, you know, I'm really interested in geriatrics. I love taking care of the elderly people. I think they face, you know, a lot of unique challenges. A lot of this comes from, you know, seeing my grandmother as a child. She lived with us and I helped take care of her, and I saw some of the challenges that she faced. And then, you know, during my rotation, I took care of patient X who, you know, was 85 years old and faced these challenges, and I love talking with her and her family. So you want kind of a story for why did your interest develop? Why do you want to go into that specialty? And then kind of what you see yourself doing with it long term. You know, most big residencies in the US, if you're thinking of kind of the big name schools, want to hear that you're going to go into academic medicine. Research, especially for international graduates, I think is important. So this is kind of one area where you can definitely stand out in your CV, because there are a lot of US candidates that don't have a lot of research on their CV. So this is one area where you really kind of want to take an active part and try to get at least one or two things. You don't have to have some big publication that was some huge original research project published in the New England Journal of Medicine. You know, if you do, that would be amazing. I don't have that on my CV, but you definitely want something. And it's really good to have something that's already published rather than, oh, I'm working on this project, which means you kind of need to get started, you know, in your, you know, ideally first or second year. So you would have time, because projects take time. They take a lot more time than you might think. I would say minimum a year to get any project, even a small one, from start to finish, because that includes things like, you know, writing an IRB maybe, or once you submit it to a journal, it can take them 3 months to get back to you. And then they may want revisions, and then you have to take another couple of months to wait for them. So it's not just how much time it takes you, it's how much time you're waiting for other people. So I would say give any research project at least a year, and a bigger research project up to 2 years. I think that I would suggest going for smaller research projects, because again, the idea is to show that you're interested and you've had exposure and you've been able to publish something, but the object is not to have some huge project that changed medical practice. That will come later in your career. So you want to look for things like case series. Okay, we saw 5 patients with this unusual condition and we're going to write about them. A retrospective review. So that basically means saying, hey, you know, we take care of a lot of patients with HIV here. Let's think of a novel question that hasn't been asked about, you know, how, you know, maybe this aspect of their, you know, other medical treatment for heart disease impacts their outcomes, or looking at something, you know, that's already been done and trying to describe it better. Small lab correlative studies, you know, oh, we have a lot of patients with COVID. We know that COVID can cause low platelets. Let's look at our patients and see how many of them had low platelets. And then review articles. These are a lot more labor intensive. They really require looking at hundreds of papers that were already published out there and kind of reviewing what the status is of the literature. You know, they're not difficult in terms of you're not describing something new or making a new finding, but they can be quite time intensive, and you really need a good mentor to kind of oversee your work. But if you have a mentor who says, oh, I was invited to write this review article, do you want to do this with me? That would be a good opportunity, because you essentially know if they were invited to write this, then it's going to get published. If it was invited, it's definitely going to get published. So that's something good to have. I would say just avoiding big studies, like a prospective trial where patients are going to be randomized to treatment A or B. Those take years. You're not going to get finished with it during medical school. Projects where maybe somebody else is already working on it and they're like, oh, do you want to help? And they really mean, do you want to do the scut work and go through the patient charts and write down numbers, but you're not going to be a first author? That's you doing the work and somebody else getting the credit. It's not going to be helpful for you. So I would suggest not doing that. And it's also important, and this is kind of from a mentoring standpoint of things, it's important to discuss upfront that you want to be the first author on this research project, because that's really the only thing that's going to be helpful for your CV. If you're kind of in the middle of a list of 20 people that worked on the project, it's not going to be that helpful. Other pursuits, so certainly volunteer work. We're starting to take that a lot more seriously, really showing that commitment to kind of community service. It is more helpful if it connects with your interests. So I think it's great any type of volunteer work that you've done, but it's not going to be as helpful if it's something completely unrelated. But say the example of the geriatrics interest that I gave earlier. If you said, oh, and beyond that, I actually volunteered to be, a medical scribe in our local, retirement community home. That ties into your interests directly, and so would be very well received. And then anything that you do kind of related to your pursuits online. So Twitter chats, for example, those of you, the 3 founders of this group, that definitely looks great on your CV. Blogs, op-eds, anything that you've written and that goes up online. Again, I find that really cool on people's CVs when reviewing it. I can't say that the old school, 70-year-old white guy that only looks at publications is going to find it that exciting, but I think times are changing, and so we're starting to take more kind of well-rounded pursuits into account. So definitely anything that you've done, give yourself credit for it and put it on your CV. So with that, that's what I had for the slides. And I want to give you guys mostly time to ask your questions. It's totally up to you whether you want me to go through the questions that you sent me, or we can definitely open up for people's live questions first, whatever works best.
Hi. I don't know if you guys can hear me well. Can you guys hear me well?
I can hear you, but it's a little soft.
Let me just put on my headphones.
That'd be great.
Is it better now?
Yeah, perfect.
Okay. Well, hi, my name is Jessica. Thank you so much for being here this morning. Really appreciate it. And all the information you have given us has been so great. So I just had a quick question. So I was wondering, how important is it for us to also try to have another master's along with the MD, like an MPH or an MBA? Does that have any bearing on when we're applying for residencies?
That is a great question. My personal impression is that it doesn't make that much of a difference. I mean, I think it helps later on down the line. So for example, if you were going to do, say, infectious disease and wanted to work at the CDC, then having an MPH would be great. If you wanted to become a president of a hospital system, then having an MBA would be great. But in terms of applying for residency, the degree itself, letters after your name, are not going to be that helpful. If you say, while I was working on my MPH, I did this research project and got these 4 publications out of it, then that may be helpful. But in terms of just having a degree itself, it's not that helpful.
All right, thank you.
Sure thing. We got some really good questions that were sent here. So maybe I'll kind of address a couple of these while people are thinking. So one of the questions was, do grades in first and second year play a role matching into programs? For example, will just passing grades be considered a red flag? So many schools are just pass-fail during their first 2 years anyways. And so if your school is not, you actually get, a little bit of a break on that, because if they look at your CV and see pass, they may assume that your school is simply pass-fail and not no. Again, people are reviewing hundreds of applications, and unless they really get into the nitty gritty of, does this school have pass fail, does this school not? Now, if you have, say you've done 10 classes and you get, if your school, has, say, like, excellent or like, superior, high pass, pass, and fail, and they see superior on multiple things and then pass on 1 or 2 things, that may raise questions. It's more about, are there discrepancies that look large in your CV rather than what the actual grades are. So if you got, if it was like honors, high pass, pass, and fail, and you got high pass on most everything, nobody's going to look at it and be like, oh, well, why did they not get honors on everything? But if you get honors on a bunch of things and then just pass on a couple of things, if there's that big discrepancy, that's going to be more of a red flag than the actual grades that you got. So it's kind of about, avoiding big gaps or discrepancies in your CV. Oh, great question. So any recommendations for moms with children who may not have time for volunteer or research anymore? So that is a fantastic question. And I think that it's very difficult because we still live in a world that, personally to me is prejudiced against women, especially women with children, and the time that takes. Because there's no spot on your CV where you can put in, I'm a mom, but being a mom is really hard work and takes a lot of time. And, you do have to make a lot of sacrifices in terms. So I have a 4-month-old at home, and I've just realized, it's so crazy, to think that I used to be able to do an evening meeting whenever I wanted to. And now it's pretty much, nope, like I have to make some priorities, and that's not happening anymore. And you realize what you're giving up, but there's no way to say that. And you definitely don't want to, unless there was some extraordinary circumstance, say that you took a break from medical school for a year to care for a sick child, you would probably want to put that in your personal statement. But, kind of day to day, it's really hard to put that in your personal statement. Well, I didn't have time to do the research because I had, childcare responsibilities at home. I think I would try to integrate that kind of subtly maybe into your personal statement without saying, this is the reason that I don't have X, Y, or Z on my CV. You could write something in your personal statement about the challenges of being a physician mother and kind of the time it takes and the sacrifices that you've had to make. And I think that will be well received, and people in their own minds should be able to draw that conclusion that, oh, she was talking about how challenging this was to have a child during medical school. That's got to be why she doesn't have, the publications or volunteer experience. So I think I would try to kind of subtly integrate that into your story in your personal statement without specifically saying that, oh, that's why I didn't have X, Y, or Z. Another question we got ahead of time was, who should you ask to write reference letters during clinical rotations, and how can you ensure a great reference from them? So I think that it's people that you've had a good kind of camaraderie with that you work with, not necessarily who have you worked with longest, or even, you know, a rotation that you got the best grade on, but who did you really feel kind of that sense of companionship working with? Who did you have, you know, that you said, oh, this was a great team. I really loved learning from this person. Somebody that would look back, you know, a couple years from now and say, oh, I remember working with that medical student. They did a great job. So it's more about the quality of that interaction rather than what grade did you get or what specific rotation it is. Now, you definitely want at least one letter from the specialty that you're applying in, right? You know, if you're applying in medicine, you don't want 3 letters from surgeons, even if you had a great, you know, interaction with them. So I think it's strategically picking, you know, at least one in your specialty. And then, you know, other people can be outside of your specialty, but that you had a very strong kind of positive relationship with during that rotation. And being as specific as possible, say, hey, I'm applying for residency. I'd like to go to the United States. It's a very high stakes application. I know reference letters take a lot of time. Would you be willing to write me a very strong letter of recommendation? And that kind of gives them an out, because you're essentially saying, are you willing to take enough time to write me a really good letter? Other things that you could do, it's a little bit early in your careers to think about it. We generally do it kind of at, you know, fellow level and junior faculty level, but is actually draft up your own letter of recommendation. And say, hey, you know, I don't want to be presumptuous, but I've put together some of my best qualities in this draft letter. I would love if you could take this and modify it based on your own personal experience working with me. But that, at least, you know, you're giving them a backbone. It takes a lot of work off of their shoulders, and you know that at least some of the quality and the content there is going to be something that you've overseen. So that can be helpful, especially if you're asking somebody that's really busy and just may not have time to start kind of from scratch. Other questions, we talked about kind of research and being ideally, yes, it would be great to have that for matching. There's a question on how hard is it for an IMG to get a residency in oncology? I mean, in the US, you would match for a residency in internal medicine and then do a fellowship in medical oncology. And if you're able to match for a residency in a US medicine program, then you wouldn't have a lot of these challenges that IMGs face coming from an international residency program. You would not have as many challenges if you're coming from a US residency program, because that's mostly is in fellowship, you know, for oncology or cardiology or whatever, you know, they're mostly looking at where did you do your residency. So you want to get into as strong a medicine residency as you can. And then how to decide how to rank programs. And that's always, you know, a tough question, because you have to balance kind of, okay, what are my personal feelings about this program versus what's kind of the prestige of the program, and what are other things like location? Do I have family that are close to there? So there's a lot of things to take into account. Being honest, the prestige of the program, especially if you're thinking of doing a fellowship, the prestige of the program is important. And so if you have the opportunity to match into a really prestigious, say, medicine program, then you're going to have a lot better chance of getting into a good fellowship program than if you were to say, I know this program is prestigious, but I don't really like it. I'm going to go for the smaller residency program. You might have a better experience during your residency, but it's going to be harder to match into a good fellowship. But that said, if you got a really bad feeling about a place, if you're thinking, hey, these folks are really malignant, or they're not taking me seriously, or I just did not like the interactions I have, I don't think the people that are there are kind of my people, yeah, the people that I get along well with, you should not rank that program first, no matter how prestigious it is, because if you have a miserable experience during your residency and you're hating it, then you're not going to be motivated. You're going to get burnt out. You're not going to feel good about what you're doing. And that's going to take away from you becoming a good doctor and having, you know, a happy and productive career. So you should never rank a program highly just because of prestige, but all things considered, if things are equal otherwise, then I would rank the prestigious program higher if you still get a good feeling about the people that are there. So they're tough calls to make. And people make different decisions all the time. Again, say you had some family. If you have a young child and you need to be close to family, but you don't have that many options in the area, you may need to take those options, because that's kind of what you need to do for your family. And you can definitely explain that, later on down the line. Say then you're applying for fellowship and you're like, well, why did you go to this residency? Again, that's an opportunity in your personal statement to discuss why you made some of the choices that you made. And I've seen people make many, many, many different choices. We have graduates who need to take some time off and go back home to be with their families. We have graduates that have done long distance relationship, even from their children. We have people who have gone to smaller programs because of family reasons. So there's people make all different types of choices, and it's only what's right for you. Nobody else should be looking and saying, oh, why did you make that choice? And then a good question, if someone wants to get into neurosurgery, should they try to match in general surgery first? There is a direct match into neurosurgery that, I would recommend trying to do. It's the same thing as like a plastics program where you can do a general surgery and then try to do, a more specialized type later, but there is a direct match in neurosurgery, and that's kind of the best route to go if you can, if you have kind of the scores and the grades to go for that direct match.
I had another question for you.
Yeah.
So I was wondering, having experience in the healthcare field, like being a nurse, an MP, EMT, any of those things, how does it help us as well?
Yeah, I think it's mostly kind of the learning how to get along with people. You have some background in terms of interpersonal interactions. How do I like interacting with patients? That somebody who's never kind of been in the medical field before they start medical school would not have that experience. So, one thing I could think is it may help with your specialty choice kind of sooner rather than later. I always advise people when they're thinking of how do you choose a specialty, not just what interests you, but what type of interactions do you like to have with patients. So for example, if you're a person who has, my husband has ADHD, so I can say this without, but if you're a person who has ADHD and wants to be doing something different, all the time and really likes a high paced, exciting thing, maybe you should think of something like emergency medicine use. Something where you need to stand and do an 8-hour surgery all day is not going to be for you. So even though you may find, that type of surgery specifically interesting and love it, doing 8-hour surgeries all day, every day for the rest of your career, if you can't, stand still for more than 30 minutes at a time, is not going to be a good match for you kind of personality wise. So it's what types of interactions do you like to have rather than just do you find the subject matter interesting? And so as somebody with experience, as, an EMT, as somebody who's been an NP, I would imagine that you've had some of those interactions with patients before and can kind of more quickly narrow down what types of interactions do you like to have with people.
So Dr. Marshall, I would love to hear how you decided on hematology, or I guess how you got there, because I'm not really sure if that's like a direct thing, or did you have to do a fellowship?
Yeah, absolutely. Absolutely. So I did a kind of circuitous route. So I did a hematology oncology fellowship. And again, kind of in this system, you basically do, so I did an internal medicine residency for 3 years, and then I did the 3-year hematology oncology fellowship. And that interest kind of in hematology oncology went back to actually when I was an undergrad. I was trying to get some research experience, and I worked with an oncologist, and he was just an amazing mentor overall. So I actually went into medical school thinking I'd probably do medical oncology. So he did lung cancer specifically. I have an interest in women's health as well. So I was like, I might do breast cancer. I have to say, having like a predetermined specialty choice, it can be helpful, but it can also be harmful. So, from the helpful standpoint, it's nice because you can say, I know specifically what rotations I need to focus on, what I need to do really well on. It'll help me kind of pick my electives. So it's easier because you can say, I know exactly what I want to do and what I need to do to get there. On the other hand, I don't know if I gave other specialties kind of as good a look as I could have. I have an interest in women's health. Should I have considered OBGYN more? I actually like the quick, interactions with patients. I could have been happy in emergency medicine, but I didn't necessarily give things a chance because I had already kind of predetermined, oh, this is what I want to do. Now, people can be very different. So my husband is in cardiology. He's an electrophysiologist. And he said, I always knew I would go into medicine to become an electrophysiologist. I would not be happy doing anything else. And that's fine too. His choices were very well defined for a long time ahead of time. And that's great. But I think for somebody who doesn't 100% know, you want to really make sure to give everything a chance because you never know what you're going to like or not. And so I matched into the hematology oncology fellowship program after my medicine residency. And I was still thinking, okay, I'll probably do breast cancer. And then I did not really so much like the patient interactions with breast cancer as I did the hematology interaction. So I do basically just non-cancer, non-malignant hematology. So I do clotting and bleeding disorders. And I had no experience in that in residency, actually. So I really got exposed to it only for the first time during fellowship, but I thought it was really fascinating. A lot of it was kind of inpatient, really significant decision making that needs to be done quickly. So it kind of appealed to that side of things that I like. And I'm also able to integrate the women's health in there. I see a lot of patients who have kind of bleeding disorders and have really bad menorrhagia, who have clotting disorders and need to take hormones, and your risk of clots increases while pregnant. So how do you manage that? So I was able to kind of integrate those different interests, but I definitely, made that change from oncology to hematology actually during fellowship. So, you may be the type of person that's known since they were 6, they want to be a neurosurgeon. Or you could get to, almost time to choose a residency and still not be 100% sure. I know people who have applied actually to more than one residency type. Usually they're related, pediatrics or medicine/pediatrics or something like that. But, there's some people where they'd be happy doing a lot of different things. And so I think giving everything a choice or a chance is really important.
Thank you.
So what are some of the things you would say we could do to stand out as students during our rotations? What are things you look for that you like to see in your students?
Yeah, I like to see people that are really interested in the patients, in the subject matter. So somebody who says, hey, Mrs. X came in and she has heart failure. I did some reading about heart failure and here's a question that came up. So not just kind of doing what you need to do or what you're assigned to do, but actually showing initiative beyond that. And also spending time talking with patients. I'm sure you guys hear this all the time, but as students, you have the most time to spend with patients, because hopefully you have fewer patients. Hopefully they're not overwhelming you with a million patients, but you have a lot fewer patients than the residents or the attendings and consultants. So you have more time to spend with each patient. And that's, the type of thing where you may uncover something that nobody else on the team was actually aware of. For example, this person keeps coming into the hospital with fluid overload in their heart failure, and you find out it's because they don't have access to a scale at home. So when you tell them, hey, you need to call us and take some medicine whenever your weight goes up because it means you're getting fluid on board, they're embarrassed to tell you that they don't have a scale at home and can't afford one. And if you uncover that as a medical student, your team would love you because then we can say, hey, how do we get, this patient a scale and help them take care of themselves, help them stay out of the hospital, but having the time to sit down and really talk with patients about, their health concerns and what's bringing them in, and finding details about their home situation, and their struggles, I think is super important. And I love when I see students do that.
Thank you.
So again, I don't want to make it like super awkward and make you guys sit there in silence without questions. So we'll give it a couple more minutes. And
I have a question I'd like to ask you, Dr.
yeah.
Marshall. You explained, that it's a good idea to have research on your CV, and I just wanted to know, what would you recommend as a good, I guess, the best way to make up for that, being, students that we are starting out, with the pandemic, and we just really haven't had as much opportunity to engage in research as, some of our counterparts, maybe students that have started before us. And I just wanted to know, what would you recommend as the best way to make up for that?
Yeah, and I think, especially those of you that are first and second years, there's nothing to make up for. You're still pretty early in your medical student journey. So actually now is a great time to start thinking about who might I want to reach out to as a research mentor, or who could I ask about projects, especially if you're a first year, you're a second year, you have plenty of time. There's a lot of really, you want to see what is the population of patients in your hospital, what are their needs. But I would imagine, with COVID, there's a lot of questions that come up, specifically related to that. I've seen a lot of successful research projects that are actually studying, what is the impact of COVID on X, Y, or Z. So I think, at this point, in your training, you definitely don't have to make up for anything. I think it's about finding the right mentor and reaching out and saying, hey, I don't have a lot of experience with research, and nobody expects a medical student to have experience with research. I don't have a lot of experience with research, but I'm very interested. I'm going to be a hard worker. I've thought about potentially, if you bring an idea forward, they would love it. I thought about potentially looking at this. Is this something that you'd be interested in working on with me? I've also had students reach out and say, hey, do you have any projects that I could work on? And that's absolutely fine too. But if somebody comes with an idea for a project, that's really hard to beat. So I would say just, give yourself, a couple weeks, a month, start thinking about what are some interesting things that you might want to take a look at, very small projects. Can I find 5 patients, that I can study about X, Y, or Z? Or is there somebody that was a great professor that you really liked and really got along well with, and you could ask them, could you be a research mentor for X, Y, or Z? Again, it's not so much about, do you have like the perfect project? It's definitely about having a good mentor who's going to help you learn the process of research and help you get something published. So sometimes it can even be in an area that's not directly related to your field. But if they're a good mentor and can help you get something published, that's going to go a long way.
Thank you.
I have a question. So there is a program that we have at SGU called Pair Learning Group. And basically it's when you've finished one term and now based on your GPA, you're eligible to tutor kind of the younger terms. And though it is a paid opportunity, my question is that still considered volunteer work in the eyes of people who are looking at your application?
Yeah, absolutely. And you could also put it in there as kind of teaching. So that would be another category. You don't have to necessarily put it in as volunteer work. You could put it in as teaching. So that, and again, most residency programs, the whole mission is education. And so if you're showing that you're doing teaching, as a student, I think that's great. Yeah.
Thank you.
Hi, my name is Hafsa, and I'm currently a first year. And so I had a question regarding rotations. In terms of where you choose to, because of course for rotations you could choose which area or which state you want to go do your rotations in. Does that really play a role as to where you could get matched or your chances of getting matched?
Yeah. Are you talking about doing kind of away rotations or?
Yeah, anything included, away as well.
Yeah. So I think that, it's more about, are you doing a rotation with somebody who can write you an excellent letter? So that's what you always want to keep in mind, not to make it so transactional, like I will only do this rotation if somebody can give me a good letter, but that's what's the most important. It doesn't so much matter kind of where you did it, what state it was in, as is it with somebody who's going to write you a really good, strong letter? And so then it becomes more important in the specialty that you want to match in. So, say you're going to match in surgery, then probably your pediatrics rotation doesn't matter so much, unless you happen to find, a great person who could write you a strong letter. But mainly it matters, where do you do your surgery rotations, and are those people you're going to be working with going to be able to write you strong letters? So it's kind of thinking about, what is my specialty? Those are the most important rotations. And is there going to be somebody at that site that can write me a really strong letter?
All right, thank you so much.
Sure.
I also have another question. It's regarding the STEP exams. So now, since step 1 is a pass/fail, I was actually I was wondering, based on what criteria would it be a pass/, because a lot of times students do pass, but what is it? Is it like a curve, or do you know?
Yeah, so they take a look at it differently every year. And it's probably something where they set, they look at people's scores. So they can't say, oh, a score of X is going to be passing and Y is going to be failing, and keep that the same every year. I would imagine that they set a standard for, we want about this percentage of people to pass the exam and about this percentage to fail, which sounds scary, but I hope they would set, the percentage failing as quite low, maybe 5-10%, something like that. But basically they're going to have to look at the results every year and kind of choose what is the score that's going to be pass or fail, and it'll probably differ from year to year, but you would actually never know that, because all you get back on your score report is pass or fail.
To kind of piggyback on that same question. So we know step 1 is pass fail now. So our residency program is also going to look more to like step 2 CK, and also as IMGs, should we shoot to try to take the step 3 before before residency, or like just to kind of like set us apart, or
Yeah, that's a
what are your
great
thoughts on
question.
it?
So I unfortunately do think there may be some more focus, or maybe it's fortunate. I mean, if you're a really good test taker, but there may be more focus on the step 2 CK, because that's the only kind of numeric score you're going to have. I think it would be really hard to get step 3 in before applications, because you're applying kind of, during your 3rd to early 4th year. So it would be really hard to take step 3 before then. Most people take it kind of 1st year of their residency. So that would be bumping it back kind of quite a bit. I also don't know if you could even physically do that, because there has to be some separation between step 2 and then step 3. So you'd have to take your step 2s early enough to get your step 3 in. So I think if you are a good test taker, I would put most of your energy into studying for the step 2 CK. If you know that you're a bad test taker and you were able to pass the step 1, even sometimes if you can delay the CK until, after your residency application is sent in, that might actually be helpful. There's no way that you could have delayed sending in that step 1 score, right? But now, because you can sometimes take step 2 CK, in your 3rd to 4th year, if you know you're a bad test taker, if you know your score is not going to be great, you might want to actually try to delay step 2 rather than try to get step 3 in early. Yeah, that would be my advice. But again, I think that it's now going to be more focused on those letters of recommendation, on the what else is there in your CV. And then we got a question about many people I know would have applied for hundreds of residency programs. Would you recommend that? Also, would you recommend applying for a backup specialty? So 2 very good questions. I think hundreds is too many. I think that, first of all, financially, that's probably not feasible for most people to apply to hundreds of residency programs. I think it's more about kind of strategically applying to residency programs. I mean, you may want to apply to, say, 10 that are really top residencies, 10 that are kind of middle tier residencies, and 10 that are lower tier residencies, and kind of see where things go from there. I wouldn't apply to, the 50 top residencies and just keep it at that. I wouldn't say I'm going to undervalue myself and I know, I'm not going to get into a good residency, so I'm only going to apply to, not very great residency programs. I wouldn't do that. I would spread it out a bit. But certainly I think, yes, obviously as an IMG, you do need to apply to more residency programs, but it also gets really trying on you in terms of time and how are you going to fit all of those interviews in. I mean, it's basically a day per interview, and you want to be at your best on the interview. So you don't want to be, oh, I've done 30 interviews and I'm really tired for number 31, but that was the one that I could have gotten into. So I think it's kind of being strategic. It's saying you're going to split it up between really good middle tier, lower tier residencies and have, I would say at least 10 in each. If you're going for a very competitive specialty, say, neurosurgery, you may need to do that kind of more 40 to 50 programs. But I think more than that is only going to be extra expense, perhaps extra time, and not serve you as well. In terms of applying for a backup specialty, that depends on how passionate you are about your specific specialty of choice. So if you say, I really want to be a neurosurgeon, but, push comes to shove, I don't match a neurosurgery residency. I'd rather, do a general surgery residency than have to reapply in a couple of years, then yes, that's very reasonable. If you say, the only thing I can see myself doing in medicine is neurosurgery, and if I don't do neurosurgery, I'm going to be miserable and I might as well go into industry, then it doesn't make sense, because then you're just going to be doing a residency that you don't like, which is going to be quite trying on your emotional status, on your time. So it really depends. Is that the one thing that you can see yourself doing? In which case, no, if you don't match, you're going to have to basically take some time off, do some away rotations, do some more research, get to know people at different centers, versus, hey, specialty A, I'd be 100% happy doing. Specialty B, I'd be 80% happy doing, but it's a lot easier to get into. Then that actually makes sense to think about having kind of a backup specialty.
I actually have a question regarding the matching. So I've actually heard of a few IMGs who have struggled, as in they have applied to a lot of programs, but they didn't really get a lot of interviews and couldn't match. So in such a case, like, how would you say that 50 programs would be enough? For me, I'm interested in pediatrics, but still I'm like, okay, should I apply to all of the programs available, or how do I make that decision?
Yeah, I think for the super competitive programs, again, the question was like, should you apply for hundreds of programs? And that seems like a little bit overwhelming to me. If it's a specialty that's quite competitive, then applying to all the programs makes sense, because usually the more competitive, let's say like a neurosurgery, there's not going to be 500 programs out there. If there's 50, 60, 70 programs, you may apply to all of them because you're probably not going to get interviews at all of them. Now, if you apply to, say, if you're saying doing pathology and you apply to 100 programs and you get 50 interviews, that's going to be too much, right? So I think the number depends on specialty, and it also depends on kind of how competitive you are as an applicant. If you're at the top of your class, if you have really strong recommendation letters, obviously you need to apply to fewer programs. If you're, have solid recommendation letters, but are kind of in the middle of your class, maybe don't have a research project, then probably you would want to apply, at least kind of apply to, 50, 60, 70 programs, knowing that if you are, lucky enough to get a lot of interviews, you can always turn them down, right? So I definitely know people who have said, hey, you know, I actually got more interviews than I thought I would. And you can cancel interviews. It's a lot easier now in the COVID era because we're doing everything virtually. So you can always cancel interviews. But, you know, for some people, it's just not kind of financially feasible to apply to the 100 programs. So then I think it's having a serious discussion with yourself about, okay, how competitive of an applicant am I? If I can afford to apply to 50 programs, you know, maybe I should be applying to 50 kind of like middle to lower tier programs, because it doesn't make sense to kind of apply for the top 10 programs and waste those spots for myself. We're almost at the end of our time. I'm really happy to see all you guys here and excited to see where your journeys take you. I'm definitely, you know, available for questions. Always happy to come back and do another session. So I hope you guys thought that this was helpful. Awesome. And for you guys that founded the group, congrats. That's really awesome. I think that's such a great thing that you're doing, and hopefully, you know, word will spread and more people will join.
Thank you so much.
Thank you so much.
Yes, thank you.
You know, firstly, we would love to thank you so much for agreeing to share your time with us and all of this insight. I mean, it really has been so helpful. And I hope that all of you were able to, you know, enjoy her information as much as we did, the three of us. And I also want to thank all of you guys for coming and sharing your questions and, you know, having this session with us. And we just want to encourage you guys, you know, to continue to interact with our social media so you can keep updated. And when we have more sessions like this, you know, maybe even have Dr. Marshall again, you will be able to attend. So, you know, I want you all to have a good day. And again, thank you so much, Dr. Marshall. I really, really enjoyed this.
Absolutely. Absolutely. Thank you all.
Thank you.
Thank you.
Have a great day, everyone.
Great day.
Hey.